Good afternoon. My name is Kathleen Taylor. I'm a DNP student, Year 2 at Loyola University of Chicago. The title of my project is Implementing a Clinical Decision Support Bundle for Diabetes Management. It's an evidence-based quality improvement project. 30 million people in the United States are living with diabetes. It's the 7th leading cause of death in the nation. It's also the leading cause of kidney disease, blindness, lower limb amputations, heart disease, and stroke. The prevalence of diabetes has more than doubled since 1980. And according to the Veterans Health Administration, 25% of veterans have a diagnosis of type 2 diabetes. Individuals who are at risk for type 2 diabetes, they can postpone it by participating in an empowering behavior modification program known as Diabetes Self-Management Education, DSME. It's a 6-week program guided by evidence-based standards. It's proven to reduce A1C by 1%. It can reduce the onset of diabetes complications and improve quality of life. But regardless of the benefits, only 5 to 7% of people appropriate for DSME were enrolled in the program. And it's partly due to lack of referrals. The PICO question is for primary care providers, physicians, nurse practitioners, and physician assistants at 4 VA clinics, does the implementation of a bundled evidence-based clinical decision support tool compared to current practice increase the number of consults placed to an evidence-based diabetes self-management education program? The evidence-based initiative is to create an evidence-based clinical decision support tool, which is an order set bundle at the point of care containing all the recommended labs, orders, and consults, including the DSME, which is strongly recommended from the VA DoD Clinical Practice Guidelines for Diabetes Management. The CDS tool delivers all evidence-based orders in one place by clicking just one button. It's provider-directed and patient-centered. The conceptual framework used for this project was the Ottawa Model of Research Use. It's a framework for adopting innovations. You assess barriers and supports, you monitor the intervention and the degree of use, and you evaluate the outcomes. For the project plan, the purpose of the project is to implement a clinical decision support tool to increase the compliance of clinical practice guidelines by the VA DoD for type 2 diabetes, and also to translate the evidence into practice. The design is a quality improvement project. Project timeline, 12 weeks starting in February 2021. The participants are 31 primary care providers at 4 VA clinics in Illinois and Wisconsin. For evaluation, the process indicator is the utilization of the order set bundle, and the outcome indicator is the number of DSME consults placed over a 12-week period measured bi-weekly, so 2, 4, 6, 8, and the final 12th week. And the results are pending currently. The implications for practice are CDS tools can promote evidence-based guided care for primary care providers and type 2 diabetes patients. And by using these tools, such as the order sets, patients can be properly managed, treated, and appropriately referred to DSME. Patient care can be improved as the interventions are based on evidence-based guidelines. Not only that, but more guideline-based order sets can be created in the future for other chronic diseases such as COPD. The sustainability of the project is strong. It saves money, saves time, and saves lives. It saves time for the provider because they don't have to go around looking in different menus trying to find all the different labs and the different consults for the diabetes patient. It saves money for the facility because the cost of VA patients for readmission is rather high. And saves lives, this is for the patient. In addition, providers receive an end-of-the-year bonus for clearing what we call clinical reminders at the VA. And that's when they order all the needed exams, labs, consults for a patient. When they do this, it clears the clinical reminder for the patient, and they do receive a pay for performance bonus at the end of the year. In addition, having provider input from the beginning of the project is important because it'll make sure that the provider is using the clinical decision support tool. Now, as I said, the results are pending, but I have attached my references, and I'd like to acknowledge and thank Dr. Poronsky, Dr. Klopp, and Mr. Mark Bisbee for helping me and supporting me during this project.